Well, good evening, everybody, and welcome to Prostate Cancer Explained. This is part of the King Edward VII Explains series, where we try to explain conditions and diseases to people like yourselves. And thank you very much indeed for giving up your time and joining us this evening. So my name is Mark Emberton. I'm a professor at University College London and a consultant urologist at UCLH. So I'd like to thank Barney Baxendale for organising not only this series, but this episode of the series. And I really look forward to the feedback that you'll give us so we can run this again. And obviously we'll incorporate any feedback that you have to constantly try and improve it. So the way we're going to run this evening is we're going to have some short little talks, no slides, about just over 5 minutes from each of our speakers. We've got some fantastic speakers. These are kind of international experts in prostate cancer, all have slightly different areas of expertise, and the expertise is very complementary to each other. We'll start with Caroline Moore, who is Professor of Urology at UCL and also a consultant at UCLH. Caroline, would you like to say hi?
Hi, yeah, thank you all for coming. It's good to see so many of you coming, and really looking forward to the questions later.
Thank you, Caroline. And Bijan Khoubehi, who's consultant urologist at Chelsea and Westminster Hospital. Bijan?
Yeah, thank you, Mark. Hello, everyone. Thank you very much for coming. And again, same sentiments, everyone. We hope you'll enjoy the session.
Great. And Paul Cathcart, who's urologist at Guy's and St Thomas's Hospital, just south of the river. So we're covering the geographic extent of the metropolis. And so the only thing you really need to know is that you have access to the Q&A function. So at the bottom of your screen, press the function that says Q&A, and in that you can write questions down. And I, during the questions and answer session, will try and pick out questions to reflect those questions, and then I can direct them to the various speakers. So we'll start probably with the big questions. So why do men get prostate cancer? Well, of course, we don't really know the answer to that. People have said, in fact, Mukherjee has said that cancer is the price we pay for the extraordinary diversity we see in the human race. So the ability for cells to change over time results in them being to change in ways that we don't want or expect. And that essentially is cancer. With prostate cancer, there's no one big genetic mutation that takes place. We see that in some cancers. With prostate cancer, it seems to be lots of little hits over time, lots of little small genetic changes that allow the cancer to deviate from the original healthy cell to one that looks less healthy but can't maybe spread, to one that can invade but maybe not spread, and then with subsequent hits, one that can invade and indeed spread beyond the prostate. Now, as most of you know, most men are destined to get prostate cancer, but fortunately that prostate cancer is not going to affect their quality or quantity of life. And in fact, in many studies that have looked at men's prostates in their 70s and 80s who've died of other things, the majority of those individuals will have it. And as you'll hear today from all the speakers, the challenge is to identify men at risk of, or men who get, clinically significant prostate cancer. So cancers that, if left alone, will impact on the quality and quantity of life. How do you know if you've got prostate cancer? Well, you don't really. If you wait for symptoms, it's usually too late. People confuse urinary symptoms from big prostates with symptoms from prostate cancer. They very, very rarely overlap. And so we need tests, and you're going to hear about those tests in just a minute, to try and identify individuals at risk. Is there anything we can do to prevent ourselves getting prostate cancer? Well, not really. Prostate cancer is obviously associated with being a man and with age. Those are two principal drivers. It also has an increased tendency the further away you get from the equator. It has relatively low incidence in Southeast Asia, for instance, and much, much higher incidence in Afro-Caribbean men, in West Africa, and also in the West Indies and in African-American men. And the reasons for that are not entirely clear. Obesity seems to be an issue. Men who carry a lot of weight, it seems that their T cells, which protect you against prostate cancer, are somehow deficient. And that's something that's just recently been recognized and is obviously something that we need to understand. Can anybody do anything to prevent it? Not really. Stay fit, eat well. Some people have looked at vitamin D. Some people have looked at statins. Some people have looked at metformin, which is a drug we used to use for diabetes. It's not clear whether any of these really work to prevent prostate cancer, but there are ongoing trials and a lot of mixed results. So that's the background to prostate cancer. I'm going to now move on to Bijan Khoubehi, who's going to tell us about certain strategies of managing prostate cancer which don't involve direct treatments. Bijan.
Hi, Mark. Thank you. It's always difficult to follow Mark, such a great speaker. I think my remit originally starts with a little bit about the diagnosis and a little bit about the minimal treatment, in other words, no active treatment. So I'll try to go through diagnosis. As some of you know, this happens over months, and we're going to try and speak about it in 2 minutes. So I'll try. The commonest way nowadays in Western countries, people diagnosed with prostate cancer is through a blood test called a PSA test, which essentially the doctor does it for you. It measures a specific protein that's produced by the prostate and no other gland. Just a couple of things I want to say about PSA is that what you need to understand, there is no level below which or above which prostate cancer is certainty. It is a continuous. The lower it is, the less risk of having prostate cancer, but by no means there's a level of prostate PSA that one can say definitely you won't have a prostate cancer. The second one is that it goes up in various conditions of prostate. For example, if you have an infection within the prostate, it will increase in size. If a urologist or a doctor puts a catheter in or a tube that causes the bladder, it will go up, it will put up the PSA, it goes up as we age. So having a slightly raised or high PSA doesn't necessarily mean cancer. And that's where normally the patients got referred to us, or the GPs take it maybe a bit further, depending where you are in the country. The next step is trying to do a prostate examination. Now, this is falling out of favor because neither the patients nor doctors really like it, but it still remains a quite important test. And up to about, depending on what study you look at, a certain percentage of patients are only diagnosed on abnormal rectal examination. Having said that, because of the next test, which is the MRI scan, most people are referred nowadays to a urologist with a high PSA will end up having an MRI scan, which looks at the prostate in much more detail. Now, I know some of you are patients and you might have been through this process. Once the MRI is done, there's a scoring system, which there are two different ones. One is called PIRAT, the other one is called LICAT, but they're very similar. And they score you from 1 to 5. And again, there's no MRI score that one can be certain there's no cancer in your prostate, but scores of 4 and 5 normally mean that you could have a high risk of developing or having high grade of prostate cancer that's significant for you in your life. Doesn't necessarily mean you will definitely have it. That's the important thing. So if a urologist says that your prostate is abnormal on MRI, doesn't necessarily mean you've got cancer, but there is a chance. And there's an area which is called the PIRAS 3, which is the middle of the road, where one can't be sure. And then it's a discussion between the doctor and a patient whether to move to the next step, which is the prostate biopsies. And that's the biopsies and histology is the definitive way of diagnosing prostate cancer. There's no other way of for certain knowing someone's got prostate cancer in 2021. Now, I'm conscious of time. There are various ways of doing the biopsy, but the best way in 2021, to our mind, is doing it transperineally through the skin between the back passage and the scrotum. And again, that can be done under local or general anesthetic. The MRI is usually nowadays used to take samples from the areas that are looked abnormal at the time, and the samples are sent off, and pathologists will get back hopefully within a week or two, and you'll be informed of the diagnosis. Now, I'm sure some of you know the aggressiveness of prostate cancer is based on something called the Gleason score, which goes from 6 to 10. And unfortunately, maybe we come back to this, but there's no real time to go through details of Gleason scoring. But it goes from 6 to 10. And it's suffice to say that a lot of patients are diagnosed with Gleason 6 prostate cancer, or even a low-grade Gleason 7, who will not need any treatment. And it's an important thing that we know now from studies. When I first became a consultant, we were treating people with Gleason 6, and that's about 13 years ago. Now, very few people with Gleason 6 should have treatment, because we know we actually do them disservice. We do not add anything to their quality of life or quantity of life, but we actually, by treating them, can give them side effects. This is called active surveillance. But the important thing is to note that this is not forgetting about your cancer. This is us keeping an eye on it. And if your cancer gets worse over time, we will act on it. And as such, the outcome of treatment when the cancer gets worse, because in 30% it does get worse, is the same as if you have the treatment straight away. So if you've got Gleason 6 or low Gleason 7 prostate cancer, active surveillance remains a very, very good option. Now, Mark, I know I've run out of my 5 minutes, so I'm going to stop there.
Well, thank you very much, Bijan. And we're grateful to Bijan for being here tonight, because he's on call for Chelsea and Westminster. So if he suddenly disappears, there's a urological emergency happening just down the road. So that's wonderful. So I'm seeing 3 questions already from Dick, from Bill, and Mr. Hulbert. We will come to those at the end. 3 excellent questions. Some of them cover areas that we're not formally covering tonight, as it's impossible to cover everything. And some of them we might address in future meetings, and we can invite oncologists and radiotherapists, but we will address your questions. So Bijan, thank you very much. And now we move to Caroline Moore, who's going to talk about some of the new treatments that she has led the world in developing that are now offered to men with prostate cancer. Caroline.
Thank you. So in the olden days, and some parts of the world are still in the olden days, prostate cancer was a yes or no question. Did you have it or did you not have it? And the treatments were all directed either to the whole of the gland using surgery or radiotherapy, or you were simply monitored. The MRI scan has been revolutionary, and it means that we can see where the cancer is inside the prostate. And that means for those men who've only got cancer in one area of the prostate, we can treat just that area of the prostate. A little bit like a woman with breast cancer who in the olden days would have had the entire breast and all the lymph nodes removed. If she has a small cancer these days, she may well just have the lump removed and perhaps some additional treatment later on. So in prostate cancer, because we can now, with the use of MRI, see where the cancer is, if it's simply on one side of the prostate and it's of an intermediate grade but not a very high grade, then there's a number of ways that we can treat that. So one of the ways that we use most commonly is called high intensity focused ultrasound, or Haifu. And that's heating the prostate by using a probe in the rectum under anaesthetic to focus ultrasound energy and bring the area of interest to a very high temperature to kill the cancer. We have other treatments, including freezing treatments known as cryotherapy, and even more modern treatments, including photodynamic therapy, which uses a drug activated by laser, and nanoknife electroporation, which uses 4 different electrodes to pass a current across the tumour. And for people who are interested in the option of a smaller treatment, we need to have a detailed MRI scan reported by some of our excellent radiologists, biopsies of the area to make sure that the area we think is a cancer, and the areas that we think are cancer-free are indeed cancer-free. And then there's a discussion of preferences. And I think prostate cancer is quite unusual in this, in that many men with localized disease are faced with a whole range of different options. Some have said it's like going to a restaurant, not seeing any of the meals and needing to choose something quickly. So somebody might be offered active surveillance, a small treatment like the ultrasound treatment, or radical prostatectomy. And sometimes it's the tumour features that will influence that treatment more than anything. But often it's the choice of the patient about whether to have a bigger treatment, which may be more impactful in terms of side effects early on, but less chance of needing an additional treatment later, or a smaller treatment, less side effects, but higher likelihood of needing some more treatment later on, or indeed monitoring and seeing what happens. And often that decision about which treatment to have can be difficult, and there can often be quite a need for some decision support there. Most of these minimally invasive small treatments that just treat one area of the prostate will be done under a general anaesthetic, but as a day surgery procedure, so potentially less disruption to people's working lives than some of the other treatments. And in fact, Mark started focal treatment in the UK with Haifu probably 20 years ago now, I think, Mark, wasn't it? My son was about 4 months old and he's now at university, so it's quite a while ago. And with the team at UCH and other colleagues across the country have developed a programme of investigation of these newer treatments to see where their rightful place is in the armamentarium of different options. And we offer these both at King Edward VII, and we offer them at UCLH, the hospital that Mark and I work at, and it's offered at a few other hospitals across the country. And I'm happy to have any further questions on the details of those later.
So Caroline, thank you. So yeah, already some questions have come up on focal, which we'll come back to now. So one of the things we try to do as a group is to risk stratify with precision. So what that means, you might hear that word a few more times today. I'm getting a little bit of feedback from somebody who's got their microphone on. And so that men don't have to choose in the way that Caroline's described, that we can direct men to the most optimal treatment for themselves, their wishes and their preferences for their prostate and for their cancer. And sometimes that's conservative policies, we've heard from Bijan. Sometimes that's a focal treatment, as we've heard from Caroline. But very often men have such a large amount of disease or have disease throughout the prostate that nothing short of treating the whole prostate, either by removal or by radiotherapy, is going to be enough treatment for them. Paul's going to speak a little bit to that now and address some of the issues with modern surgery for the prostate.
Thank you, Mark, and good evening, everybody who's joined us tonight. So I was tasked with the question of why and when would robotic prostatectomy be the best option? Now, virtually all surgeries to remove the prostate are done using robotic assistance now. So really that question means, when is surgery the best treatment option? The thing about prostate cancer, and Mark has alluded to it, is it very much is complex and nuanced to the individual patient. There is no one size fits all. Care really needs to be personalized to the patient. We take into consideration disease factors, patient factors, and also patient preferences, which is what Caroline was talking about earlier. And I think that's really important. So the disease factors, well, if surgery is going to be entertained, patients really need to have clinically significant disease. And that's disease which is going to affect a man's life expectancy. And we have just discussed that before. And there's a huge spectrum of disease, from indolent, quiescent disease, which is never going to spread. We really don't want to treat that, compared to much more aggressive disease, which will metastasize. And those patients need early radical therapy. Now, clinically significant tumors tend to be a higher grade, higher stage, in other words, spread beyond the capsule of the skin of the prostate. And patients tend to have much higher PSA levels, over 10, over 15, even over 20, for example. Patient factors, now they're super important. Now, a chap needs to live for quite a long time before his prostate cancer will metastasize, spread, and kill him, even if it's a really aggressive tumor. So life expectancy is really, really important. So we don't normally expose patients to the side effects of whole gland therapy unless they have between 8 and 10 years life expectancy, because prostate cancer, even in high-risk tumors, is going to take a long time to spread and impact on that man's life. So men going for surgery tend to be fitter and younger in general. Patient preferences, Caroline's touched on this, and it's super important. One can't assume that a man would always go for the longest life. Men will often, and there's some really interesting studies that looking at trading off quality of life for length of life. And one man's weighting of life expectancy versus quality of life will be very different to another. And so it again needs to be very much nuanced to the individual. So we tend to operate on patients who have high-grade, high-stage tumors with a long life expectancy, and men who are willing to trade off the risk of incontinence and impotence for extending length of life. Specifically, if we want to look at surgery over other treatment options, if you're going to compare surgery with, for example, focal therapy is, or surgery is better for multifocal tumors, so tumors spotted throughout the prostate. Sometimes patients who have a focal or a small tumor, but it's very aggressive, then those patients sometimes tend to go for a whole gland approach. Patients who maybe have problems with the follow-up of focal therapy, for example, if they can't have MRIs, if they have a pacemaker, or for example, they don't live locally. Focal therapy, you need to buy into the treatment paradigm, so you need to be in close contact with your urologist regularly. So multifocal tumors, high-grade tumors, tend to go more for surgery versus focal. If you're looking at radiation as an alternative to surgery, tend to operate on younger patients with surgery because of the slightly increased risk of a secondary malignancy with radiotherapy. Patients with certain genetic conditions such as BRCA gene mutations, which is a cancer gene mutation, they tend to be better treated with surgery as opposed to radiotherapy, for example. And then there are a number of contraindications to radiotherapy, which means that surgery may be slightly better. So patients with very large prostates are probably best not treated with radiotherapy. Patients with very severe urinary symptoms before their prostate treatment, so urgency and frequency, those symptoms will get worse with radiotherapy. So a patient may choose or elect surgery over radiation. Patients with inflammatory bowel conditions or bowel problems where they open their bowels a lot, again, they aren't best suited, for example, to radiotherapy. Alternatively, patients with maybe a previous history of a pelvic malignancy, such as bladder cancer, those patients may be less likely to be recommended radiotherapy over surgery. So that's why we tend to go for surgery in certain selected patients. But I would say that this is not cookie cutter, it's very individualized. One thing I'm really proud of at King Edward VII is being part of a multidisciplinary team working with Mark and Caroline and Bijan and our radiation oncology colleagues, because we can offer such a comprehensive range of treatments which many centers throughout the world really can't do. So it's great to be part of this team and nice to talk to you this evening. I hope that was helpful.
Paul, that's fantastic. Thank you very much. So we're getting more questions now, and I think we'll start with the question from Mr. Dick Morris, which is about castrate-resistant cancer. And Dick is asking that this means that the cancer doesn't depend on testosterone to proliferate, but yet we treat it with anti-testosterone medicine. And he says that's a bit strange. Now, we don't have a medical oncologist on the panel today. I think the answer to that is that it's a continuum. And we start off treating prostate cancer that has spread beyond the prostate with some hormones to interfere with testosterone. The cancer recedes and then gets used to that environment. And then we treat with more intensive reduction in hormones, and the cancer recedes again and eventually gets used to that environment. So it's a kind of war of attrition. And so although it does seem a bit odd, it's a question of degree. The cancers themselves can make testosterone, and some of these newer drugs stop that. And we discovered about a decade ago that a lot of the testosterone came from organs other than the testicles, and a lot of the new drugs do target that testosterone production. So I think the answer to that question is one of degree. But eventually, if a cancer is treated with hormones, eventually it becomes resistant to our ability to suppress testosterone, and then we have to use other things like chemotherapy and something called PARP inhibitors and types of radiotherapy that target the cancer metastases. So I hope that helps explain that really good, insightful question. So we've got a big question now, and Caroline, it is the screening question, and it always comes up. Who's got the screening question? So yes, it's Bill. Bill has raised it. Thank you, Bill, for raising it, because a lot of your other participants will have this at the front of their minds. Why is it that we don't have a screening program in the UK or indeed elsewhere, given what I said earlier, is that the only way to find this disease is to do a test? So Caroline, why haven't we got a screening program up and running?
Okay, so the essence of the answer is that we tried a screening program where men had a blood test. If the blood test was high, they had a standard biopsy. If the standard biopsy, just spreading the biopsies out through the prostate rather than targeting them to high-risk areas based on MRI. And if that standard biopsy was positive, then they might be randomized to surgery or to treatment. And essentially, it wasn't helpful in reducing death. Now, that's not because prostate cancer doesn't cause death. Prostate cancer is the second commonest cause of cancer death for men in the UK. It's because the tests at that point weren't good enough. So they missed some of the really important cancers, and people were told they were fine, but their cancer kept growing and they came back when it was too late to treat it in a localized manner. And they told some men with an indolent cancer that would never have affected them that they had a significant cancer, needed treatment, and then they suffered with some side effects that weren't justified by the risk of the cancer that they had. Now, again, MRI is a real game changer, and we know it's a game changer for men who've got a high PSA or a high blood test. And we've shown that in numerous studies in the UK. I think we're really fortunate that in the NHS and privately, we can deliver an MRI before a biopsy for every man that needs it. What we don't know is how well an MRI would work across the whole range of PSA tests. So we know it works well in men with a high PSA, but we also know that PSA doesn't pick up every cancer. So we are working on this. We've just finished a small screening study called Reimagine, asking men in the community with a letter via their GP to come forward and have a PSA test and an MRI scan. And I can't share the details of those results, but it's looking very interesting, very promising. And I think this really will be the question for the next 5 to 10 years. How can we assess men in a reasonable way that's both cost effective and effective at finding the important cancers, and hit that sweet spot of finding the important cancers without telling everybody that they've got a cancer that needs treating when it's not the case?
Thank you. So it's quite clear. It's a simple question. Why isn't there a screening study? But the answer is a complicated one, isn't it? But Caroline has explained that very well. Caroline is one of the world leaders in trying to get a screening program up and running, and has developed a kind of international consortium in order to further this. So if you are pro-screening, Caroline's your friend. She's the person to contact about that. So, and I can't imagine there are many people that are anti-screening. Now, Bijan and Paul, Bijan first, anything you want to add on the screening question? Can't hear.
So yes, just one point. It is difficult. I mean, of course, Caroline's well. The problem is, as you know, all the screening is based on the populations and what happened 15, 16 years ago. And a lot of patients they feel individual and they won't have a PSA at the age of 50. And I just think we've got ourselves into a real model with the government guidelines now. You can have it if you ask for it and you know what it means. So essentially, we're having screening through the back door. And one other thing that is quite gripping, now the data from, I will not go to trials shows that actually screening for prostate cancer, you need to treat less men to save one life than from the breast cancer screening program, which has been around for 25 years. And that's just an interesting point to make, that, you know, so as men, I understand what people ask this question, and it's very, very difficult in the clinic to answer it. I personally myself have had my PSA when I was 50, and I've just had one this year. I'm 53 this year. Sorry, 52 this year.
Good. N equals 1 screening program. Yeah.
Yeah.
So, Paul, anything you want to add on the screening question?
No, I mean, I think we're moving towards smarter and smarter screening, you know, including imaging, family history, et cetera, and so I'm sure we'll get there. We will have a screening program. It's a matter of time. I know the Europeans are trying terribly hard to roll this out through Van Poppel. There's a big movement to try and get European PSA screening, but everyone's talking about smart screening, utilizing multiple tests to limit the number of biopsies and therefore target downstream effects to fewer and fewer men. And so we don't want to treat lots. We want to very select out who we identify as cancer and then selectively only treat some patients. We've done a really bad job looking for prostate cancer traditionally, treating the wrong patients, identifying patients who really don't need cancer. So there's a lot of work to be done. The problem is you need huge numbers of patients. So Caroline's work and yours is, Mark, is fantastic. So it's the future, really.
No, I think it's, thank you, Paul. That's sobering to hear. And the trials have taken a long time, some of them 20 years, and many have cost tens of thousands of pounds or euros to run. So, you know, hundreds of thousands of pounds overall has been invested in the screening question, and we're still no further. And so that kind of, you know, points to the complexity of the question. I think we do need clinical trials. All screening programs harm. Some screening programs confer benefit. And that's why we need studies to show that it's the right thing to do, in the right way, in the right people, at the right time. But I think these days we can do the studies a lot quicker than we could historically, and hopefully a lot cheaper using kind of modern data linkage and algorithms and things like that. So, so that's the screening. So we're frustrated, like many of you are, that there's no screening program. We are working very hard to try and create the next super duper screening program, which hopefully will get up and running within the next few years. So the next question is from Mr. Hulbert, which is a radiotherapy question. And this is about what patients can do to mitigate collateral damage from their radiotherapy. So I know that Paul and Caroline do get involved in some interventions that are designed to do just that, and there'll be other ones that we'll discuss as well. Paul.
Yes, I was going to talk about, but maybe it's best for Caroline, because Caroline's doing these interventions now, and I've stopped. So maybe it's best for Caroline to cover that. Okay.
I'll just say in general that radiotherapy, like surgery, has improved dramatically through technical advances. When I was, you know, a medical student or training, we used to shoot at the prostate from the left, from the right, from the front, and from the back. And that was it. That was the radiotherapy. These days, there's kind of CT, MRI planning. We check where the prostate is, because the prostate does move every day, and that the beams are shaped and targeted. And we do lots to mitigate radiotherapy effects to adjacent organs. And the two big ones are bladder and rectum. And Caroline's going to tell you about a recent innovation in relation to protecting the rectum.
Yeah, so completely agree with Mark. The modern advances, in the olden days, people had an X-ray on day one. and it was assumed that the prostate was in the same place at every treatment for the next 30 odd days. Nowadays, it's much more nuanced than that, and that's really helpful. There is a specific intervention called space OR, which is insertion of a gel between the rectum and the prostate so that the rectum is much less affected by the radiotherapy at the edges of the prostate than it would be otherwise. It's not available universally. There are many, but not all, NHS hospitals that use it, and it does seem to be useful in reducing the rectal side effects. As Mark says, it's fairly new, and like all of the things in prostate cancer, we're always really interested in the 10 and 20-year data, but if the early data is good, then we look at using that.
Good, thank you very much. Bijan, do you want to add anything? So there are lots of things that are done. Radiotherapists require the bladder to be fairly full during radiotherapy, so that the dome of the bladder is outside the field. Men are encouraged to have to empty their rectums beforehand, so that the prostate is in roughly the same place each day. So there are lots and lots of things that are done routinely now to try and make sure that the radiation beam hits the target. And of course, there have been many advances in the way that the radiation beams are produced, and indeed in the nature of the beams. And people in the audience will have heard about proton beam therapy, which historically you had to go to Czechoslovakia to get, and that the famous child who went there. But now you can, very soon you'll be able to get it on the Tottenham Court Road, and you can currently get it at the Christie Hospital in Manchester. Those are the two proton beam therapy units that the NHS has invested in. Whether or not prostate cancer has a big place initially, I think is in doubt. I think it'll be children first, back of skull, and sarcoma, which are the principal indications for proton beam therapy, but I'm sure there'll be a place for prostate in the future. Bijan, and anything else on radiotherapy? How about brachytherapy? Do you want to just tell us a little bit about brachytherapy?
Yeah, just a couple of, I'll come to brachytherapy. Just regarding the external beam radiotherapy, the same way as we all say, and Paul and I go to robotic prostatectomies and have them for years, and we just think it's the best way of doing it. The same with radiotherapy. I think in most units, and this should be commonplace now, that you should have what's called an IMRT, external beam machine, which is and every day or every session they have a quick CT scan to see where the prostate is. Just as that's improved both the side effects and the accuracy of the radiotherapy, I'm told, a lot. None of us are radiotherapists, but that's just want to add that. But yes, the brachytherapy. It's an interesting thing, brachytherapy, Mark. As you know, about 25 years ago, 30 years ago, we all thought this is going to be the complete game changer, and none of us are going to any prostate surgery or give radiotherapy from outside. But it hasn't proven to be the case, and at least the numbers in US and UK are declining, to my best of my knowledge. And essentially, it involves putting seeds into the prostate, radioactive seeds. And I think the reason they're declining is, one, you can't treat every prostate with it. You have to have a certain size. You can't treat every cancer with it because it's a whole gland treatment, and aggressive cancers don't tend to do very well with it. And of course, it is another form of giving radiation. So to my surprise, in the last 25 years, it's declined and not increased. So I don't think going forward, it's going to be a huge uptake of brachytherapy, because the newer technologies like you and Caroline are introducing are probably going to take it over.
Okay, good. So the next one is a challenging one. So what about the potential of niraparib in advanced prostate cancer? Well, we don't have any medical oncologists here, so I don't think it's reasonable for us to go into any detail, because none of us are expert. But just for those in the audience, this was alluded to earlier. This is a PARP inhibitor that helps healthy cells repair their DNA and cancer cells not repair their DNA, and that's how you get your selective effect. And there are many trials in London, and we're very well blessed in London. In the major centres have lots of trials running, particularly with this agent. And so if you are eligible for it, and there are distinct eligibility criteria, you will be offered this new agent, but usually after previous treatments for disease that has spread beyond the prostate. That's about as far as I can go. Does anybody else want to add anything on this agent? So what we can do next time is actually get some medical oncology colleagues and radiotherapists to come and speak about the nuances of these types of treatment. So Michael wants to know about his finasteride. So finasteride is interesting. It was tried as a prostate cancer preventative therapy, and it was successful in reducing the risk of the prevalence of prostate cancer over a period of 4 years, but it was never licensed for that. What I don't know from Michael is whether the finasteride has a prostate cancer context. I suspect not. I suspect he's using it to shrink his prostate. And he asked, does he need to take it at the same time every day? Who shall I ask now? Paul.
I don't think it makes a huge difference what time of day he takes the finasteride. I don't know how old he is, but I would recommend taking medication at the same time every day, simply so that you make sure you only take the right number of tablets. To be honest, it just logistically, life is easier if you organize things like that. But it's not going to make a hair's bit of difference whether he takes it at different times of the day for his prostate. It's also taken for men with hair loss, so but a much lower dose. I see a lot of young men taking 1 milligram of finasteride, usually actors and things, but no.
I was going to jump in with that joke when you said not a hair's bit of difference, but it does make a difference to hair. Yeah, Donald Trump famously takes 1 milligram of finasteride a day. It's called Propecia. And maybe Paul will start quite soon as well.
Oh!
I think finasteride is a great agent. I think it's a very good agent. Some men worry about it because it can affect in about 5 to 10% of men erectile sexual function, mainly erections, also a little bit of libido. And there was a scare about a decade ago about whether it kind of selected out aggressive cancer growth. That's been kind of challenged now with good data, and there's no suggestion or concern that it does. But it probably stabilizes the prostate and probably stops prostate cancer progressing from the, pussycat Gleason 3+3 to the more aggressive. But I remember I said probably based on one randomized study. So thank you for that question. Now, this is a good one for Bijan and for Paul. If my consultant offers me a manual prostatectomy, so traditional, what we call an open prostatectomy, and not a robotic, should I walk away? Bijan.
Interesting question. Very interesting question, actually. So look, Paul and I, we advocate robotic surgery and we're doing it, as you know, and the reasons for that are various. But let me just be honest with it. Up to now, no one has shown that robotic prostatectomy in the long term, and long term I mean after 3 to 6 months, has got any advantage over open surgery, both regarding the cancer cure rate, regarding impotence and incontinence. There is some evidence, some good evidence actually, that the incontinence returning, in other words, leakage stopping, and impotence or potency improving is better with robotic surgery. But regarding the cancer cure rate, there's no difference. What I would say is, if your surgeon is competent and knows what they're doing, I think that's more important than whether they're doing it open or robotically. The issue though is, if you have it robotically, you normally go home the next day. With open surgery, it takes much longer to recover. There's more pain. There's a higher chance of blood loss. Those are definites. But long-term, 6 months down the line, apart from a bigger scar, is there any difference? Very little. But short-term, the first few weeks, there is significant difference regarding the pain, recovery, that sort of thing. I don't know what Paul thinks.
Paul.
So it's a question that is rapidly no longer being asked, because if you look at the number of men having prostatectomy in the UK, 4% are having open surgery. So hardly anyone is having open surgery. So, there's a great trial comparing open with robotic prostatectomy, and there was no real difference in the hard outcomes, because the study reflected 2 very good surgeons doing the operation. So it's all about the person doing the operation. It's not really about the technique for the important outcomes. But because so few open prostatectomies are being done open now, it's not really a question that comes up very often now. Volume is very, very important. So if only 4% of prostates are being done in an open manner, then those surgeons are probably pretty low volume. And then it's probably wise to go on the robotic approach unless they can prove their data and demonstrate that they have really good outcomes. Really.
There are some very famous surgeons who still insist on doing open prostatectomy. Steve in Munich, several people in America, but they are getting older. They're quite senior, and they were probably too old to convert, and were very high volume, very good surgeons. But there aren't many of them left now. Each year there's fewer of them. And if you want to be operated by an 86-year-old, go ahead. So thank you for that. I think that's very helpful. But it would be, I think we'd all be a bit surprised if a man in the UK were offered an open prostatectomy today.
It does happen. I mean, I had a patient just last week who was offered an open prostatectomy, so it is still happening.
I think it's more common than you think, especially about 200 miles from here, slightly up north towards left.
Okay, right. It's amazing what you learn on these webinars. Now, this is a good question. This is from Willem, and this is really about kind of advanced late stage treatment. So in other words, typically when a prostate cancer spreads beyond the prostate, we move to what we call systemic therapy, which is where we use drugs or injections that treats every cell in the body. But interestingly, recently now, we certainly treat systemically, but when tumors develop, and we can see them developing on these fantastic new scans that we have, we bring back radiotherapy to treat the tumors and reduce the overall tumor volume that patient is experiencing. And so this is a question about that. Can we use things like radiotherapy if you develop obvious metastases whilst on systemic therapy? Caroline.
Thank you. So I think in terms of, two questions in there. So one, is radiotherapy helpful at some stage? And there are two potential uses of radiotherapy in this instance. And one is if there is a particularly painful spot outside of the prostate, and radiotherapy can sometimes be used for pain relief in that situation. Often when there's a spot in the spine which is painful, that it might be used in that situation. There's also a potential use for radiotherapy for men who only have a small amount of disease outside the prostate. And the discussion of that is very much dependent on the different studies that you look at and how you measure the volume of what's outside of the prostate. So it depends on the tests that have been used to measure that. The second part of that question is about, can it be shrunk to the stage where robotic surgery is possible? And I think it's fair to say robotic surgery could be technically possible. You could have a surgeon go in and take out the prostate, but we don't currently think that it's useful, because we know that it might get rid of the prostate itself, but you'd be leaving behind disease and might have additional problems from the surgery. So not at the moment. These things are always dependent on the diagnostic test used to define things, and we'll see what the future holds.
Great. Well, thank you very much for that. Donald is going into hospital for a biopsy very soon. So he tells us he has an ileostomy. And for those of you that don't know, ileostomy is when you bring out a little bit of the small bowel to the skin, and because of some disease that normally occurs beyond that area. And will that affect the biopsy? Well, traditionally we do biopsies through the rectum. Some people with an ileostomy have their rectum removed because of the underlying disease they have. That may or may not be the case with Donald. When there is no rectum, the biopsy is quite challenging to do, but not impossible. Does anybody want to speak to how we might biopsy a prostate where there is no rectum? Paul.
So occasionally this happens. So you can do transurethral biopsies. So you can pass a telescope down the water pipe, and if the tumor is encroaching in the water pipe, you can shave away the prostate to get some tissue. Most tumors in the prostate cancer tumors are not around the water pipe, so not really amenable to that. You can, the main problem here is when we do our biopsies, we have an ultrasound probe in the back passage, which images the prostate that allows our needles or a biopsy and needles to pass through the skin just behind the scrotum. You can, if you have a very good radiologist, apply an ultrasound probe to the perineum, which allows you to pass your biopsy probe through the perineum. It is very difficult, I must say. I always engage one of my radiologists to help me do it. Yeah.
Yeah, this is technically quite challenging. And yeah, anybody want to help with this, Caroline? Bijan, anything else you want to add?
Yeah, I mean, it's possible to do a biopsy through the skin and through the bladder. I remember as a registrar doing that quite some time ago. It's not a method I'd use at the moment. And there are some centres in Europe that do a transgluteal biopsy. So they pass a needle essentially through the buttocks. Again, slightly odd. And we do get referred these patients at UCH in particular, and we have a joint procedure in theatre. So patients under an anaesthetic, so they're completely comfortable. We use a probe on the perineum and pass the needle through that way, but it is quite challenging.
Okay.
I would say one other thing.
Go ahead.
I mean, then you need to also concentrate on what the end game is. You know, if you find the cancer, how are you going to treat it? So these patients may have had radiotherapy and can't have radiotherapy again. That's why, you know, they had their bowel removed. Surgery, incredibly fraught with difficulty in a hostile pelvis. So if the treatment is hormone therapy anyway, sometimes you don't need any tissue diagnosis. You can make it based on the MRI alone. So.
Okay, just quick fire answers for this one. Will Haifu overtake prostatectomy? Paul?
I hope not.
So I see these as complementary. So I mean, the number of patients having Haifu is going to dramatically increase, but surgery is also moving to higher and higher risk disease. We're treating different populations. I think they're mutually they go together. It's all part of a range of treatments.
Good answer. Bijan hopes not. Caroline?
But let me just clarify that. I think, sorry, I don't think one can overtake the other. I don't think it's a competition. I think essentially is what is best for the patient for a particular type of it. And of course, as we know, we're doing more and more advanced cancers, and then there's of course there's recurrences to deal with, both from radiotherapy, from Haifu, and also from surgery. So there's all different forms of treatment available. So I don't think it's a competition.
There's a lot of Haifu questions here, actually. My consultant is anti-Haifu rather than pro. I think you can get a second opinion is the answer to that. You know, some people just don't have enough experience to have a view, and doctors are naturally conservative. We're taught to be conservative. We're taught to be skeptical. And so that's not an unreasonable position if you haven't had much experience. But there are plenty of places around the UK that you can go and get a second opinion now. And there was one more about, yes, is there a maximum volume for Haifu? No, is the quick answer to that. It depends where the cancer is. Haifu has a maximum focal length, so its reach is 4 centimeters, but we can get at most, not most, but about 60% of cancers are within 4 centimeters. And then we have other forms of treatment for those that are beyond that. Okay, who wants to say a little bit about Stampede? Caroline.
Yeah, very happy to talk about this. I'm delighted that I'm working with one of the key people in Stampede in my next research program. So for those that don't know, Stampede is for men who've been diagnosed with cancer that's spread outside of the prostate. And the great thing about Stampede is the trial design. So we know in prostate cancer, new things come along all the time. And if we wait to try them out against the old thing in sort of groups of two, the new versus the old, and then the new versus the old going on, it takes a really long time. So the Stampede trial was designed that you could have people having the standard treatment and then have smaller groups of people having the new thing to see how well it worked and compare them all. stop the new thing if it wasn't very good, or take it into routine practice if it shows itself to be a really good thing. So I think, yeah, there's a lot of hope for Stampede. It's already come up with some great additions to what can be used, and because of the way it's set up in the UK, it tends to get approval fairly quickly to be a standard treatment, because almost all the oncologists take part in that study. They all agree with the results once they're there, and it gets approval much more quickly than if it was a small hospital in one place doing a similar type of thing.
I think it's just worth emphasizing, we often look to America for developments in medicine, and actually a lot of the stuff we've been discussing, including Stampede, are UK inventions. These are the results of UK clinicians and UK scientists developing new ideas. Stampede is the biggest clinical trial in existence, and is one of the most innovative clinical trials to do that adaptive design, as Caroline has said, and many others have copied. And I think we often don't recognize just how much innovation, how many world firsts we have created in the UK over the last 10 years to improve the care of men with prostate cancer. So this is interesting, yeah, about Gleason 3+3 = 6 from Bill. And this might be the last question, I'm afraid. We've, as always, run out of time. And this is the discordance. So Bill was diagnosed with Gleason 6 initially, but then was told he had T3A disease. What happened there? Did the Gleason 3+3 progress, or do you think that the Gleason 3+3 was maybe a bit less than the sum of the parts of the whole cancer that was present at the time? Caroline.
So it seems from the question, and maybe I'm reading this wrongly, that it was diagnosed as Gleason 3+3, then high intensity brachytherapy and the radiotherapy, and thought to be T3A. And nowadays we might think that that's a little bit of a mismatch, because we usually do say that Gleason 3+3 is low risk, but we also know that sometimes the biopsies can be inaccurate. And so without the full, if we're asked this question sort of clinically, either, you know, in our NHS or private practices, we get all of the tissue that was taken at the biopsy, we get the MRI scan and have a look at that. And what I expect is that this was considered, the biopsy showed a lower grade of the cancer, but from the other information, such as the MRI scan, it was felt to be higher grade.
Okay, thank you. Well, we're getting into the last minute now. So I just want to remind delegates, so people that have signed on will get a recording of this. So if you didn't catch it all, you will receive a recording. So thanks again to Barney and his team for organizing this and doing all the backroom work. We're very, very grateful for the opportunity to speak to you about prostate cancer. We love to do this. We will commit to doing it again. And perhaps you could give Barney some feedback on what you liked about it, what you didn't like about it, and perhaps some subjects that we didn't cover that we might cover in the future. So as we come into the last seconds, could I thank Caroline, Bijan, and Paul for their fantastic contributions tonight. I've learned a lot, and I hope you have. Thank you very much.